Good afternoon, everybody. We have close to 50 participants already, and I think we will get going. Just to let you know, this is the third webinar on the of supporting care coordinators. We had about 350 or a bit more in the first two webinars. So we are glad to see many of you again here, and we will be moving with the webinar. I will ask Josephine Mo if she can give instructions to how to pose questions, etc. And here with me today are Tim Lenartowicz, Director of Nursing and Health Policy, Joanne Crawford, who is the Chair of SHINEC, and Sheena Howard, who is the Chair of the Ontario Family Practice Nurses. Welcome to everybody. Josephine.
Hi, everyone. So if you're logged into the WebEx interface, you'll notice that there is a chat box on the lower right corner, and you can use this to ask questions or comments throughout the webinar. We'll reserve the time for question and answer for the end after the presentation, but you can still feel free to submit anything there, and I'll try to address the earliest opportunity.
Okay. So again, what you are attending today is Health System Transformation, welcoming all of the attendees. We are 50 and change now, and the topic is on supporting the role of care coordinators and also the transition of care coordinators from their current location in CCACs to the future location, which will be employed by the LHINs, a portion of them in hospital care as discharge planners, which already are working in that capacity, and the great majority, about 90%, who will be located most likely in primary care. Just to give you a bit of what you will hear today, first of all, needless to say that we have heard from care coordinators that they would like to have the support of RNAO on this transition, and we are absolutely delighted to do that in several capacities. First of all, to let you know as much as we know, and sometimes advancing some knowledge that may not be public. Second of all, to offer you to either continue your membership or re-engage as a member of RNAO, given that, first of all, it enables you to be in the loop all the time through our communications. It also enables you to have professional liability insurance as part of the membership. We also want to present to you today a bit of historical context, what RNAO envisions are the next steps and how that compares to Bill 210 and the reintroduction of Bill 210. An overview of RNAO membership services, including two of our key interest groups that are very much in line with your role, which is the SHINEC and Ontario Family Practice Nurses. And then an opportunity to pose questions from you. So in terms of the historical context, let me run by you a bit of a diagram of how we see health system effectiveness taking place. First of all, at the foundation of it always is timely access to quality care that is person-centered. And within that, the four key pillars that will allow us to move that. First, health human resource planning, then robust interprofessional practice that is more than just getting along and smiling and at best having a coffee together, but is really respecting the expertise of each professional and accounting for it as we make clinical decisions. And then full and expanded scope of practice for RNs and for MPs and for RPNs within their scope, and interprofessional evidence-based practice and policy. So really evidence-based practice for nurses and evidence-based practice for all the professions. The key principles that any high-performing health system has is strong interprofessional primary health care that anchors the system, accessible person-centered services, and adequate and appropriate utilization workforce, as well as care coordination that is located in primary care. And the issue of care coordination located in primary care is not only a matter that RNO has been pushing for a long time, but it's a matter also that has been adopted by the Ontario Primary Care Council, of which we are founding members. A bit of the timelines here. So in June 2012, you may remember, RNO issued a very strong report that is in our website titled Primary Solutions for Primary Care. In it, we focus specifically on the role of RNs and RPNs, simply because we already had given a lot of focus to nurse practitioners, had made many advances to the scope of practice and role of nurse practitioners, including the ability to prescribe without a list, and including being able to practice without a collaborating physician as mandatory, et cetera, et cetera. So Primary Solutions to Primary Care provides within its long and solid report two role descriptions, one for RNs and one for RPNs, which I would really encourage you to look at, because for those of you that are in primary care, it may be very helpful for you to look at those role descriptions. Then in October of 2012, we issue ECHO 1.0. Both reports receive strong accolades, not only within Ontario and across all political parties, but actually nationally and internationally, and they have been used in many other forums. Then in December 2012, a couple of months after we issue our report, Deb Matthews issued the Health Links, which was the beginning of really bringing together all the sectors. In April of 2014, seeing that the role of CCACs continue intact despite the auditor's reports, and seeing that we believe strongly that care coordination needed to happen in primary care, we issue again ECHO 2.0. And in October of 2014, Ontario Primary Care Council position statement adopted care coordination as being located in primary care and reference ECHO. In March 2015, the Home and Community Care Report came about, again urging a strong emphasis on home and community care and making some linkages to primary care. And then in May 2015, Minister Hoskins then accepted all the panel recommendations. Then came two very serious reports by the Auditor General, the first in September 2015, the second in December 2015, both stating that the cost of CCACs was over the roof, and that mainly expressing concerns that access to care was not being fastened, and yet the expenditures on administration of the CCACs was too high. The Minister then issued a report on December of 2015 called the Patient's First Discussion Paper, and he publicly acknowledged the influence of ECHO and also referenced RNO's ECHO report within his paper. And then on May 2016, you may have heard we issue a report, Mind the Safety Gap and Health System Transformation, where we actually speak about the fact that although the minister has a very ambitious agenda that RNO strongly supports, the minister does not account for the few needs to move that agenda forward, which is health human resources. And in doing the analysis of nurse practitioners, RNs, and RPNs for the province, we...
Oh, I know why I can't do that. This doesn't work.
someone needs to put on hold the line. Issues a very clear a gap that there is the lowest RN per population in Ontario, and yet the number of RPNs is increasing, but at the expense apparently of RNs. And that, although we need RPNs in the system, and always we have, it cannot be at the expense of RNs. And given that the system will become so much more acute, hospital care, because the discharge will be faster based on the minister's agenda, home care because patients will get home in a more complex situation, primary care because we need the skills to make sure primary care anchors the system. So we are saying we need to reclaim the role of the RN. And then in June 2016, the Patient First Act is introduced, and we will speak about that. Tim Lenartowicz will speak about that in a few minutes. So I want to point out that ARNEO's leadership has been consistently at the forefront and consistently pushing aspects that we believe are essential for person-centered, high-quality care in the province, and that without this, we cannot simply get to health system effectiveness. The issue of replacing one category of nurses by another, including RPNs by unregulated workers, etc., is not what's going to deliver the end goal of health system effectiveness. So we have been influencing policies through submissions, correspondence, meeting with key officials, participating in consultations, and the results are very clear, and the minister has been very generous in acknowledging the influence of RNAO. Let me then move to what's next and ask Tim Lenartowicz to speak a bit about ECHO and then about Bill 210.
Great. Well, thank you, Doris, and good afternoon to you all. Thank you for joining us. So a reminder of the ECHO model. So this was released first in 2012 and again the 2.0 and 2.14. And really what ECHO aims to do is to anchor the health system within primary care and positioning primary care to serve as a coordinating body for all health services, with an emphasis across the system on looking at disease prevention, chronic disease prevention and management, health promotion, and mental health and addiction. As well, to enable all of this, we're positioning the LHINs as the single health system planner, funder, and monitor, including enter into service agreements with all providers within the system. ECHO also aims to increase primary care coordination. Now this is what we refer to as horizontal integration within primary care through the development of primary care networks. Thank you. So Bill 210 was first introduced in the legislature in June of this year. It does create a legislative framework to transfer and dissolve CCACs as structural entities. But it's important to note that there's still a lot of complementary policy work that will be needed done. So if you're looking at Bill 210, it really is the foundation of the House, and then there is policy that will be needed to build the walls and the roof. So some of the key features of Bill 210 include an expanded mandate for the LHIN that includes more explicit reference to health equity and the social determinants of health, the creation of patient and family committees, and that was a recommendation that we had included in ECHO since 2012, the creation of sub-LHIN regions for planning purposes. And again, if you look to ECHO, we also included those local primary care networks as well. The bill includes a number of supervision as well as investigation powers, both for the LHIN ministry. We know that CCAC care coordinators are likely to become employees of the LHIN and located within primary care. Now, the current status of Bill 210, as you likely know, last Monday the legislature was prorogued, which means that all of the legislation on the order of paper has been wiped off. Now, that being said, the government has committed to reintroducing its bills. So we do foresee that Bill 210, although it won't be Bill 210 anymore, but the Patients First Act we do expect to be reintroduced in the fall. So in terms of implementation, so a lot of information we can glean, again, from the policy that will be needed and as discussed within the discussion paper that was released by the Ministry in 2015. And so in that discussion paper, it talked about CCAC employees providing supports to clients would be transitioned to and employed by the LHINs. So RNAO supports that the care coordinators would be employed by the LHIN. However, we want to see them truly located within primary care, and we see that being accomplished through a secondment. As well, the discussion paper identified that our coordinators would be focused on LHIN sub-regions and may be deployed into community settings, and the examples given include FITs, CHCs, or hospitals, and Doris had also talked about that, how we envision a portion of the care coordinators would be in hospitals to facilitate discharge planning, and then the balance, the vast majority, would be located within primary care settings. Largely the interprofessional primary care teams, which include nurse practitioner-led clinics, family health teams, community health centers, as well as Aboriginal health access centers, and then also leveraging those sub-LHIN regions to create those primary care networks to provide coordination assistance to group and solo practices. The discussion paper also referenced that home care would be continued to be provided by service providers, and RNAO wants to see, of course, that continue with an emphasis on quality and requiring home health care agencies from RNAO's perspective to undergo accreditation. And also, RNAO wants to see the continuity of services being offered by home health care providers strengthened so that a client really can expect that their home health care or support service provider is going to provide them with a continuity of services, rehab, nursing, personal support. And this is really in an effort to minimize the number of agencies that come into Ontarians' homes, which we have heard stories of from patients, clients of 6, 7 plus. Some come in on weekends, some provide rehab, some provide all over the place. And then the last piece here is LHINs would be responsible for the long-term care placement process that would be currently administered by CCAC. So in terms of RNAO's recommendations, we really want to see this as an opportunity for substantive health system transformation that includes the true realignment of CCAC functions within existing areas of the health system, locating the care coordinators within primary care through a secondment, taking the significant savings that will be produced through the elimination of CCACs and to reinvest that into service provision with a focus on home health care and support service delivery, as well as mental health and addiction. Transitioning mental health nurses in schools into public health units for those who meet the requirement to become a public health nurse, which is a baccalaureate degree, and that's under the Health Promotion and Protection Act. And then those who don't meet that requirement to transition into the mental health sector, as well as transitioning NPs and CCACs to appropriate primary care settings and or home health care providers based upon their role and expertise. We are saying not to transition the CCAC executive positions to the LHINs, given the implications that that will produce when transitioning the CCAC executive into the LHINs. Given the scope of the then LHINs executive positions, that would create, from our perspective, an unrealistic need to heighten and increase the funding needed for those positions. And so what we are advising is that first there be an assessment done of the administrative capacity and to be able to identify where there may be gaps as opposed to automatically just transitioning all of the administration. So for those who are interested in a more visual depiction of what care coordination within primary care can look like, we do have here this process map that we've mapped out, and we've created this in collaboration with both primary care as well as CCAC care coordinators. It's included in our response to the Patients First discussion paper. And really we envision two, categories of care coordination. One is involving current CCAC care coordinators who would be coordinating services given your significant expertise to those with the most complex care needs within primary care. And this really does a good job of showing how that process would unfold. And then the second group would be existing primary care RNs. There are several thousand within primary care already. Unfortunately, as Primary Solutions for Primary Care has identified, not practicing to their full scope potential. Therefore, those care coordinators providing, or those primary care RNs coordinating care for the rest of the population that will have varying degrees of complexity across their lifespan. As well, we've also included a template role description for a primary care-based care coordinator. And again, this was developed in collaboration with both primary care as well as CCAC care coordinators to really outline the breadth and the expansive role that this would take. And we really see this as being a resource that can be adopted by primary care organizations to ensure the most effective integration of care coordinators within primary care. And both of those pieces are freely available online on our website. I'd invite you to take a look, and you can all, by all means, connect with me after the webinar if you'd like more information or detail on any of that. A question that we commonly get is, well, what about our caseload, and how will that be monitored and established? So one of our recommendations has been for calling for provincial standards for care coordination and health system navigation. Partially this will ensure that no matter where a person is within Ontario, that they will consistently have the same access to coordination services. It will also help to standardize processes across LHINs as well as sub-LHIN regions while enabling also for flexibility to be incorporated at the local level. And so this can be accomplished through a risk-adjusted scoring system based on both medical as well as social complexity that could be developed or adapted based upon existing systems. And I know that there are already systems that are being used, and I think it's a good opportunity to be able to assess the strengths as well as areas of limitation of that system for it to be adapted within the primary care context. As well, and I already mentioned this point previously, that the care coordinators from CCAC would be focusing their services on those the complex needs, and then primary care RNs would coordinate services for the remainder of the population that would have varying degrees of complexity across their lifetime as they may run into episodic moments of illness, but also a great opportunity to be able to emphasize health promotion and to help ensure that people are able to stay healthy.
So thank you, Tim. So before we go to membership aspects, I would like to go for a minute back to the ECHO model and share with you what we think will happen and what we think may not happen. So we are quite confident that the CCACs are going to be devolved into the LHINs for their functions of health system planning, funding, etc., and accountability. We are also quite confident that the care coordinators will be hired by the LHINs, but will be located, the great majority, about 90% of them, in primary care, primarily in interprofessional teams of primary care. We do know that Bill 210 did not bring full speed public health into the umbrella of the liens. We also know that there will be tight connections between the boards of public health units and the liens. And my guess will be that depending on how effective that is, the future of that issue of bringing the public health within the liens will be or not, with the likelihood that there is a strong appetite for that to happen. It remains to be seen if hospitals or primary care will be really the sector that will take more of a front stage in care coordination. Needless to say that RNO, not out of respect to hospitals, but because we believe that hospitals should be reserved for taking care of the most complex ill individuals, that we actually have a very strong preference that it be in primary care, as the ECHO report mentioned and team reviewed, simply because any high-performing system, primary care at the forefront. So we will continue to push for that, not to the expense of the role of the hospital, but yes, as a coordinating body. And then we will be also very much at the forefront of pushing that specialty care, whether from doctors, physicians, or interprofessional groups, be fully brought to bear into primary care, as opposed to having wound care clinics that are not linked to primary care, but really to have all of those aspects really incorporated in primary care, especially when you are talking about mental health and addictions, etc. So I just wanted to mention, and as you ask questions, you can ask us more questions of what's our crystal ball, and we will be happy to answer. Let me very briefly, to respect our colleagues on the phone also, review with you some RNO member services that could be very handy to you in your role as care coordinators as you move forward. First of all, you do know, I hope, that RNO is a professional association for RNs and PEs and nursing students. We represent about 41,000 of our colleagues and speak out for nursing and health, and are quite bold and vocal and extremely influential, whether it is with politicians or with the public, and of course the public through the media. Our members are extremely engaged. They are engaged in the future of the association, and they're also engaged in moving policy forward by means of action alerts, etc. And I would love my colleagues to actually comment on that as you speak, Joanna and Sheena, not only about your interest groups, but your engagement with RNO and our ability to mobilize members in a way that, quite frankly, no other organization, whether nursing or otherwise, can do. The benefits of membership are professional development and career advancement. You do have about 40% discount on all of our educational offerings. We also offer many that are free of charge. We, as I said, work with members, especially with the Assembly, which is about 160 leaders from across the province, in visiting MPPs, both in Queen's Park on the Road, Queen's Park Day, et cetera. Those events are starting as we speak. And then in the famous Take Your MPP to Work during Nursing Week. One of the very important benefits is professional liability protection. Professional liability protection, which is mandatory by the College of Nurses of Ontario, is part of the membership fee of RNO. So the membership fee of RNO is $256 for RNs or NPs that are not unionized, and that includes PLP. So it's $256 period, the whole package. and is about 276, I believe, or 278 for those that are unionized. And right now we have a special promotion for RNs and NPs that gives you an additional 2 months. So if you sign today or tomorrow or whenever, you have your membership up to October 31st of 2017 for the same price. RNAO allows you to stay connected, not only through the events that I mentioned, but actually the journal and also the In the Loop, which is a monthly online newsletter that you receive that tells you the latest about the association and how we are responding to various initiatives. For example, now we are pushing for the rollout of the funding for improvement of compensation for nurse practitioners, the issue of NP ability to prescribe controlled substances, the issue of independent RN prescribing. The issue that we continue to push is, of course, the full-time employment, which we have been extremely successful. And as you know, also on positions like Chief Nurse Officer in Public Health Unit and Chief Nurse Executives in hospitals. So really we tackle the issues that are of primary importance to both frontline nurses, whether you are an RN, an NP, or a nursing student, as well as those that are involved in senior leadership positions. We do have many clinical resources, some of them that are free of charge, like the guidelines, and some of them that are at the cost, like the various institutes that we offer. And again, I said that we do offer about 40% discount to those that are RNAO members. We have a large number of interest groups. 2 of them will present today, and you will be able to see how they align with your interests, and there are many others, all of them of great importance to RNAO. And of course, there is the chapters and regions that allow you to also participate at the local level. We have many recognition awards. All of them require that you be an RNAO member, and we have financial support that we offer for going back to school, etc. Let me, that's the flyer on the RNAO membership that includes PLP, and you likely, if you're not a member, receive also cards last week in your home, and a phone call from me that is out today to remind you to join. Let me ask our colleague, the president of SHINEC, please, Joanne Crawford, to share a bit about SHINEC as one of the options that you can choose as you join or rejoin RNAO. And by the way, we have well over 70 people. I was saying at the beginning, actually we have close to 80 people, 77 to be exact. And I was saying at the beginning to Tim and to Josephine that maybe we don't need to do more webinars, but I say now, yes, we do, especially that the changes will be advanced and we need to continue to support our colleagues. So please, our colleague from SHINEC.
Thank you, Doris. Thanks for having me here today, and I just wanted to share with you some information about the Community Health Nurses Initiatives Group. We've been a special interest group for RNAO for 35 years. For some of you, this is new, but for some, it's a review. I just wanted to give you a brief overview. We're a dedicated group, board members of 14 members and 2 to 3 student affiliates who represent public health, home health, and other community health nurses, as well as education. Volunteer our time and expertise to, as Doris indicated, provide advocacy and leadership for community health nursing in Ontario. We want to be the voice and involved in health and social policy decisions. And this is really important given new impending healthcare reform, which really we want to be involved in any way that we can assist it. Next slide, please. So as far as our overarching goals, the first goal is to influence health and social policy, and we active in consultations, as Doris indicated, long-term health and social policies that impact community health nursing through advocacy. So, for example, we had a consultation on the basic income guarantee most recently, and I hope that some of you have seen the journal article reflecting the value of school health nurses. The second goal of building capacity and leadership among CHNs, it impacts our board because we want to create opportunities for community health nurses.
You are cutting off a lot, so I don't know if it's your phone or what's going on.
I don't know. Can you hear me now?
Yeah, better.
Okay, let me just see if I put you on handset. Okay, how's that?
That's perfect.
Okay, so we'd like to create opportunities for community health nurses to participate in professional development. So we have a health promotion seminar series. We also have bursaries that fund professional development. We promote uptake of the BPGs as well as other evidence-based practice. We promote and support certification through the CNA. For our third goal, we look at being active in strengthening the profile of the diverse roles of community health nurses, and that's all the various roles. We do that through education, research, and policy. We promote the value of CHN practice through advocacy, and we also engage in social media to enhance the visibility of community health nurses through public engagement. And the fourth goal is impacting our membership. So we always try to develop strategies to recruit and retain members. We also look at responding to the needs of community health nurses through our membership as well as various other forums. We offer bursaries and awards, as I mentioned before. And for the final goal, we really want to encourage and maximize student involvement. So we have a student affiliate members group on SHNIG. We also influence education. The next slide, please. So overall, I just wanted to summarize by saying what our membership provides. We provide professional development. If you visit our website, you'll be able to see what exactly that entails. We give our members a chance to network and participate in practice issues. We have professional practice committees that have been very active for public health and home health, our two largest group of members. And we also provide opportunities for education and leadership, as well as research and attendance at RNAO events, as well as the national conference. And last, we always try to include our members and invite them in forums and events so that they can be active in influencing or advocating for health policy and community health nurses. So our website's right there. If that will help you learn more, please visit it.
Excellent. Thank you very much. Let's move now to Sheena on the Ontario Family Practice Nurses, please, and then we will open for questions.
Good afternoon, everybody. Thank you very much for joining us and for RNAO and inviting us to come and discuss with you the Ontario Family Practice Nurses Interest Group. I'm wondering if we could move to the next slide. Thank you.
A bit stronger, Sheena. We can't hear you well.
Okay, let me see if I can switch to the handset. Is that better? Can you hear me okay?
Speak a bit louder.
Okay. So the OFPNs, our objectives are to represent nurses who are concerned with primary care and family practice. Specifically, we are supporting the primary care nurses who work in CHCs, the family health teams, family health organizations, and solo family practice, and in solo family practice offices. Our concerns are to promote the quality of primary care nursing by providing mechanisms for networking and knowledge translation. We use our website and other various ways to provide up-to-date information that is relevant to primary care. We are very concerned with advocating for the primary care nurse and family practice nurses as well. We are advocating for leadership at all levels of local and provincial primary care organizations and governments. We're also acting as a nurse resource for individuals, groups, and governments on issues concerning primary care and family practice nursing. Next slide. OSPN has undergone some significant executive changes. We now have a full complement of executive members, which we're very excited about, and having just completed our first retreat in a very long time. What we're most concerned about is supporting the RNs who are currently working in the Community Care Access Center and their transition into primary care, working with SHNIG to be able to support them and to be able to engage with them. Also advancing the role of RNs who are currently working in primary care to work to full scope, working with the RNAO to influence moving the patient's first agenda forward. We're also very much wanting to promote evidence-informed interprofessional primary care practice, which we've been hearing from our members is lacking in Ontario, so we're wanting to engage more members in making sure that we're promoting that. And also, we are trying to realign the image of RNs in primary care by moving forward with a name change in our interest group to reflect the current political discourse. The name we're currently looking at is Primary Care Nurses of Ontario, which is a significant shift from family practice into anchoring primary care nurses into primary health care. If you're interested, I'd be more than happy to speak with you, but I'd also encourage you to check out our website at www.ofpn.ca. We're also active on Twitter at #PrimaryCareNurses, and one of our biggest goals is to have 50% of the 4,000 primary care nurses working in Ontario be members of our interest group in the next 5 years. So I can be reached at our website and also on Twitter at #PrimaryCareNurses, and we'll look forward to continuing working with the RNAO and working with our membership.
Thank you so much, Sheena. So just an overall reminder for our colleagues over the phone, and yes, we have well over 70 people now. So thank you for staying till this time. If you join today, tomorrow, whenever you decide to join, you get your membership up to the end of October 2017. It is $256 whether you are an RN or an NP, and it is $175 if you belong also to ONA, whether you are an RN or an MP, it's the same price, and it includes the mandatory PLP from the college. So we will urge you to go to www.rnao.ca, although I think it's enough to go rnao.ca, or to call at our 1-800 number, which I will give you in a second, 1-800-268-7199, 1-800-268-7199, and our staff will take your membership right away. Again, 41,000 RNs and PEs and nursing students, and we want you to be part of the winning team, and we want to be on your side and at your side as you make this transition. Let's open for questions, whether on the policy front or on the membership front. We will be delighted to answer. So Josephine, if you can repeat how to pose questions and then start to read the questions to us, please. Thank you, everyone.
A reminder to everyone on the line, if you're logged into the WebEx interface, you'll I will paste them.
Yes, of course.
Okay, so our first question is, what will it look like for the mental health and addiction nurse clinical team?
So what we are actually asking, and is part of the ECHO report, team will tell us in a second on what page it is a relocation of some of the teams to either home care or to schools or to etc. We see the current specialties within CCAC to be relocated into one of the existing sectors where they can benefit the most.
Is on page 22 of ECHO 2.0.
And in the case of mental health, we have specifically...
Yeah, mental health nurses.
That is excellent. Thank you, Tim. Or within primary care, actually, also. Because one of the top priorities, actually, of the government is on mental health and addictions, as you know. And with all the issues happening in school, the more people we can put on the upstream in schools, it will be very beneficial to really focusing on tackling the issues early on. And if not there, then in primary care as part of an integrated primary care system. Excellent question. What are the estimates that government has given?
Legislation, I mean, there's a strong likelihood that it
You guys are completely cutting out mid-sentence and we can't hear you.
Okay, so we will get closer.
So I was just providing my estimate of the time frame. So, I mean, I don't anticipate that it would take much longer than this fall for the legislative piece to proceed. In terms of the full realization of all of the changes, building upon the legislation, likely within 2 years.
Oh, absolutely. I think within 1 year, the piece of the CCAC coordinators will be transitioned, and then within 2 years, full functioning, if not sooner. Yeah. Excellent question again. Well, let me say this. Actually, primary care, well-established interprofessional primary care does look after children and does look after complex children. So if children with very unique needs require a specialty team, the same as if an adult, for example, an adult with cancer at some points may require a different team. Those need to be connected still to primary care because that's where the continuum of care happens. So the connections between specialty care and primary care are absolutely essential.
Add to that as well, Doris, that when we released ECHO 1.0 in 2012, we actually heard from a number of CCAC care coordinators who specialize medically fragile children who were asking us for more detail. In fact, we actually ended up working with them to incorporate that in terms of ECHO 2.0. And so we were very happy to do that in collaboration with those actual coordinators who are working directly with children.
Yeah, that's what they're asking.
Excuse me? Could you repeat your question, please? Okay, I think someone had a question, but we couldn't catch. Feel free to write the question. If you can share how to write questions, will be helpful.
So there's a chat box in the lower right corner of your WebEx window, and you can use that to type and submit your question or comment.
In addition, if any of you would like to continue the dialogue on specific issues and would like to contribute to the positions of RNO, by all means, please connect. I think the best is through Josephine JMO at rno.ca, and she will give either to Tim or myself or whoever that is actually leading that the specific pieces that you are interested in joining. We would love to hear from many of you. More questions?
Yep, so the second part of that comment or that question is also you seem only interested in RNs, while in my team we have social workers and occupational therapists that are care coordinators. You expect them to be laid off?
No, absolutely not. And in fact, ECHO both 1.0 and 2.0 discuss this issue. Of course, this is a webinar for RNs and NPs, but we are more than delighted to address the issues of members of the interprofessional team. Tim actually spoke about that when we said that home care needs to provide 24/7 all the services, not only partial services, and we would say exactly the same as it relates to care coordinators. those of you that are from rehab specialties, whether a physio, whether occupational therapist, or if you are a social worker, etc., we see you very much engaged either in primary care, in aspects of care coordination, or in home care also, which will be delivering more comprehensive services. So no, we don't see you losing your position. We see you, in fact, the system benefiting even more from your position that currently is happening, and in a more continuous way, not only when a person is in a crisis situation.
Considering CMAH nurses are not part of CCACs, what is your vision for not duplicating roles?
I think I need some clarification on the acronym CMAH.
Is that the clinical, can you specify what CMAH acronym is for everyone, please? Meanwhile, you can read the next one, and we will come back to that one.
All right. Oh, Canadian Mental Health.
Yeah, I thought so, yeah. So actually, there is a number of nurses, mental health nurses within CCACs now. In fact, RNO provided the training for them when the Canadian mental health nurses were integrated within CCACs. So they are part of CCACs, many of them, and we are saying that they need to now be integrated within either primary care or within schools, depending if they meet the requirements of public health nurses in schools that do have specialty in mental health services.
Head of the RNAO.
Excuse me? One of you is commenting on the site, and we can hear the comments. What we need is you to please give us the full comment so we can respond to it. We gladly will do that. I will leave a space. Maybe you can give us the comment, please.
So I received that.
Oh, great.
So
Fantastic.
Paste it here. To the mental health and addiction nurses, care coordinators, can you clarify where you see the care coordinators being placed? It sounded like it would be in the schools.
Yeah, so those of you that have specialty in mental health, we are proposing that be primarily in schools. If you do have the requirement, which is a baccalaureate by legislation. If you do not have the baccalaureate, then of course we want to still benefit from your expertise, and then it should be either within primary care or in some instances on specialty services within home care.
This individual also asks whether the RNAO has spoken to the Ministry of Education about placing the care coordinators in schools.
We have spoken with the Minister of Education, we have spoken with the Minister of Health, we have spoken with actually all the ministers. Not only we have spoken, we get ongoing calls from ministers' offices more or less on daily basis.
There are some physicians' offices that do not want to have a care coordinator working in their office. Where would they be housed? Yeah,
we are fully aware of that, and more often than not it's because of space issues. Not all the offices have the space necessary, and in fact, we are recommending that most care coordinators be located in interprofessional primary care teams, and that then a solo physician that doesn't have the capacity to incorporate an interprofessional team can subcontract the interprofessional care, including care coordination, from that other team. So I hope that helps. So yes, we are aware of that.
Would you expect that all of the current CCAC offices would be closed?
My estimate would be that they should be closed. They're very expensive settings. And as Tim also alluded, in ECHO 2.0, we are also saying that the executive level leadership of CCACs ought not to move automatically to the LINs, because we'll make the LINs very, very expensive. So depending on the necessity of the LINs and the expertise of the individuals, it should be a fair process for applying. and then benefiting the lien from that expertise. And where that's not feasible, then there are many other parts of the system that need the expertise of all of us, quite frankly, in all roles and positions.
Okay. Would there be removal of CCAC care coordinators from the hospitals?
No, absolutely not, and we have absolutely supported that they not be removed. Currently, those CCAC care coordinators that are in the hospital are funded 50% by the hospital, 50% by the CCAC. We would like to see those care coordinators fully employed by the hospital sector. We don't know if that will be the case or if they will be employed 50% by the lien, 50% by the hospital, but we want them to continue to be fully anchored in the hospital, and that's exactly the same that we want for the rest, to be anchored in primary care, not in an office outside of primary care. So it very much parallels what's happening now with the hospital CCAC coordinators.
Can you provide further comment on how the CCAC wound care programs and initiatives will work with wound care clinics and or primary care, community health centers, and family health teams? Excellent
question, especially that RNO is extremely engaged on the issue of wound care. As you know, not only we have the fabulous guidelines of RNO on different aspects of wound care, but one of the guidelines on wound care for foot ulcer for people with diabetes was uptake by the Council of the Federation, meaning all the premiers of the country for national uptake. And also, as you may know, we are lobbying extensively and advocating on the issue of offload devices for people with diabetes that to prevent foot ulcers, and likely we'll have a great deal of success with that. There is an interesting tension forming between having standalone clinics for wound care versus having wound care integrated within primary care. We are of the view that although you need specialty expertise, that needs to be tightly integrated within primary care. So I would be extremely interested in hearing more from the individual that asked the question as to your views and what do you believe will work the best. So if you can send an email to JMO, I would love to have a more extensive conversation with you.
What about the orphan patients who have no affiliation with a physician?
So in terms of that question, I would broaden that to a primary care provider. And we know that over the last several years, significant strides have been made to attaching Ontarians to primary care providers, with a number of enhancements being proposed in Bill 210, coupled with things such as independent RN prescribing. We're only going to see the capacity of primary care significantly grow. So for those individuals who want primary care, access to primary care services, but are having some challenges now, I anticipate there'll be significant enhancement within the next couple of years. Now, that being said, we do know that there is a very small proportion of Ontarians. It is a relatively small group who choose not to attach themselves to a primary care provider. That is their choice to do so. And within ECHO, we actually tackled that issue and identified that should they require access to home care services, that they could connect with the LHIN, who would then make the appropriate referral. And again, but we're talking about a relatively small minority of individuals here.
What happens to care coordinators that work from home? Are they expected to continue with this setup?
I'm actually surprised to hear that. I was not aware of how many care coordinators work from home. I thought they work mainly from a CCAC, so this sounds as if they set up their offices at home. Like with any other healthcare provider, our preference would be that when they get integrated into well, those that are in hospital care that continue to work from the hospital, and those that get integrated into primary care, that they actually work within, that they be located within the primary care site, because working from home, while an exception can be okay, on permanent basis, really the entire team will lose out of your expertise and the ability to connect not only about specific patients, but about broader issues that may really result in great improvements for that specific primary care site.
How do you see short-stay coordinators fitting into the system?
So what we've envisioned is that the CCAC care coordinators transitioning into primary care would be providing the coordination of services for those with the most complex needs who often require continuous care coordination services. Given, and this is building upon and leveraging your expertise, you know care coordination well and you understand the complexity of care requirements. In terms of individuals who have varying degrees of complexity across their lifespan, for example, they have surgery and are discharged, need some assistance, but otherwise are relatively healthy, we envision that the current primary care RNs would be coordinating care for those individuals.
Also, what about human resources and IT services? What happens to them?
So in terms then, that goes back to the comment I had made earlier around the LINs and engaging in an assessment of the current administrative capacity of those organizations and identifying where there may be gaps and you know, implementing appropriate measures to bridge those gaps. We do know that with the LINs, approximately 0.3% of their budgets go towards administration. With CCAC at one point, it was almost as high, I believe, as 10%, and that was identified within the General's report. So certainly there's an opportunity to enhance LIN's capacity, but the infrastructure does exist, but it also is premature to say specifically what might need to be enhanced when there needs to be that initial assessment.
And just in response to what was discussed earlier, someone provided the information that in North Bay alone, it is estimated 12,000 patients do not have a primary care provider. These are considered orphan patients.
So it will be very important to ascertain from these 12,000 patients, which is a really large number, how many of them do not want to have a permanent primary care provider, how many of them have not been able to attain one. Of course, in North Bay, we have many settings that are interprofessional. We have our nurse practitioner-led clinics that we are extremely proud, and RNO was the primary inventor or advocate to move them forward. And we also have community health centers, family health teams, etc. So again, with the colleague that wrote that question, we would be very interested in discussing more and seeing how we can facilitate that all of those 12,000 or as many as possible attain a primary care provider. And if it's an issue of spaces in primary care, we certainly can lobby and advocate based on evidence that more professionals are needed within the interprofessional teams to account and embrace as many as possible of the 12,000 patients. Thank you for sharing with us.
Once you remove CCACs and the current infrastructure, how do you see the service offers being sent and received by the community service providers?
Well, through primary care, right? The logical place in any high-performing system is not an agency arm's length, but it is through primary care. So if I break a hip and I go to the hospital and I need home care after, my discharge coordinator, which works in the hospital, will connect with the discharge, with the care coordinator in primary care and say, Ms. Greenspoon needs home care. And then that triggers home care. It also, in terms of long-term care, we know that the LINs will also be involved in understanding how many spots are available within the long-term care facilities in the region. An important piece to mention is that the discussion now at the LIN level is the formation of sub-LIN structures. In these sub-LINs, which will be around 70 to 80 of them in the province, you will have all the sectors engaged in ensuring that people receive the services that they need. So that's the structure that the government is discussing. And if you look at the diagram that we showed you on ECO and you look on the right side, we did the local primary care networks. These primary care networks, in the view of the government, need to be multi-sectoral. So I hope that clarifies a bit the picture.
The next submission is a bit of a longer comment and question. With a change in employers, hospital care coordinators in particular, this will affect care coordinators' seniority, as currently they are CCAC care coordinators, and they have seniority and benefits based on current collective agreements.
Yeah, and that is exactly why the government, and we supported that, is looking at you continuing to be an employee of the LIN, so that your seniority will not change, your compensation will not change, but you will be located fully within the hospital sector and the rest, about 90%, located within primary care, but without any changes to your compensation, whether it's salary or benefits.
Does PSLRTA provide for current CCAC care coordinators transitioning to more than one prospective employer, as historically, home care became CCAC in 1997, and then CCAC became a larger CCAC in 2007, and employees went directly from one employer to another. Also, a large number of us work from home.
So Placerta, actually, if you are employed by the LIN and nothing changes, then there is no issue. The issue of working from home, which again is quite a bit of a surprise to me, never was disclosed so much from CCACs, that likely, if you are in those of you that were in the hospital, I would assume the hospital wanted to have you on site. I'm quite certain that those of you that will be in primary care will want to have you on site too.
Will the PCAs also be moving into the LINs to provide support to care coordinators?
Could the individual clarify what PCA is referring to?
Primary care assistant. Can you please specify the acronym? There are so many acronyms today that...
patient care assistant.
Yeah, patient care assistant.
Or secretary.
Yeah. Likely, yes, they will be moving to primary care because there are many requirements for assistance in primary care.
Okay.
And we are advocating for that, by the way.
CCAC care coordinators visit individuals in their home and school settings to assess the care requirements. If set up at primary care, do you envision them doing the same thing or just assessing in the office?
Excellent question, and that's a question the government has discussed with us. So for those patients that are in the hospital, we have been supportive that the CCAC coordinator does the first assessment in the hospital with those care coordinators that are in the hospital, which, by the way, they used to be called discharge even years ago. For those that are in primary care, we do see the care coordinator in primary care doing that assessment. Now, some will be, as we said, in specialty settings like mental health, CCAC coordinators that may be in school. So then it can be a link between the school and the primary care. All of those details, by the way, have not been finalized, and your input will be hugely important. So if you want to have more discussion and provide your input, please connect with Josephine at jmo@rno.ca, and we will have more discussion. These are very, very important questions.
Okay.
How many more questions we have, Josephine?
Just one for now.
Okay. So we will take this additional question, and just to remind you to please, to urge you to please go to rnao.ca, rnao.ca, 1-800-268-7199, 1-800-268-7199 to become a member if you are not already, because much of these updates we also give to members via our written materials, and also you have the possibility to participate in resolutions that shape the future of the association directions, etc. Again, it's only $256 till the end of October 31st, 2017, whether you are an RN or an NP, and it includes PLP. And if you are unionized by ONA, which many of you are, it's only $175 from now till end of October 31st, 2017, and it includes the PLP and everything else that we offer.
Okay. So our last question for now is, now that we are looking at LIN hubs, which will require staff, is this another place where current CCAC staff would move to, or would they be new hires?
Likely a mix of both. Likely a mix of both. I mean, first of all, there will be positions that will be posted, many of them. So, I mean, a CCAC staff could apply, and other staff could apply, other people could apply as well. Remember, the role of the LINs will be, to a certain extent, much different than now, because we'll be expanded, we'll be much more accountable, we'll do whole system planning and funding allocation, and much more monitoring and accountability. So also the LINs will need to beef up their resources to be able to do all of that, so there will be many opportunities at the LIN level, many opportunities at the primary care level, and of course also for those of you that in the hospital to continue to do that role as well. I also would suggest that there will be many opportunities in home care. The role of home care will be expanded. So the future is bright, and yes, it's bright for RNs, it's also bright for NPs, and it's also bright for those of you that are from other disciplines. Do not fear the future. I don't see it as anything but positive. All the changes are, of course, always a bit unsettling for any of us, but we do not perceive a shrinking of services, but an expansion of services.
We just received another question. With the integration of CCAC and the LIN, and some executives not making the transition, do you see the LIN not being too top-heavy?
No, I hope that the LIN will not become too top-heavy, and that's why we are saying, and we said that in the submission to the government, the team will give us the page, we absolutely said that it should not be an automatic transition of CEOs from the CCACs to the LINs, not because we don't value their work, but because we don't believe that we need a new auditor report now saying that the LINs are too top-heavy.
That's on page 10 in our response to the patient's first discussion paper dated March 2016, rnao.ca/policy.
And we will be very happy, Josephine, perhaps through you, to send all these resources online to the members that participated.
You should have received those links already when you registered. It's in that automated email. But
fantastic.
If you want to email me for a direct link, you can certainly do so. My email address is jmo@rnao.ca.
Fantastic.
I'm not seeing any further questions. Someone does comment. Many of you have said thank you, and someone said thank you for answering my questions. I've been an RNAO member for many, many years.
Hope to continue to see you for many more years. We have a great deal of loyalty. Our retention of members is close to 95%, so we have a lot to be proud about. Again, we want you to be part of the discussion. We want you to be part of shaping the direction. If you have comments, if you have information you want to share, by all means, we will set up another webinar because we had over 70 participants at the end, and many of you stayed to the end, so we absolutely will set up another webinar likely within 6 weeks to 2 months from now, so that we can give you the further developments as they become known. Of course, we are in the inside and in the thick of it, so we do have quite a bit of information. The deputy, in fact, is coming to our board, so we will hear even more. The Premier called me 2 days ago. I have meetings with the Premier's office and the Minister's office, so whether it is within 6 weeks or 2 months, be assured that we will keep you fully in the loop, and we want to hear also from you, because that is our conversations with government and opposition parties. Thank you super much, and thank you, team, and thank you, Josephine, and thank you, colleagues, for joining, and look forward to ongoing dialogue. Take care.
Thank you.
Thank you. Bye.
Thank you, colleagues, and from Family Practice for you giving great information to our members. So, Joanne and Sheena, thank you so very much.
Thank you, Doris.
Bye-bye.
Thank you, everybody. Bye-bye.